So, welcome to week 6. We are halfway through this course. So, I know it's getting hard now. I know those 3 courses are all up to here. You have all of those exams coming, how to spend your time. Remember, I'm here to help you. If you need help organizing yourself, or if you need help with understanding, make an appointment. Monday, Tuesdays, and Thursdays are great for me to meet with you in the afternoon because I have morning meetings usually. So send a message. I'll get with you. This week with studying, you also have a CJ Sims, and always exam week is at 50 NCLEX questions. And those questions will be related to the exam and what's going on. I did today already an exam review. It's already posted. Professor Pace Chismar has already done a review. I've already posted it. So you've already had that start. Remember, the way I explain things might be different from someone else. So pick who you like, one who makes a sense for you, but go to two. Two different views on the same subject will help you. And there's more exams, reviews, even going through Saturday and Sunday. So pick one if you can, go to one, but at least listen to that review. I do put one announcement. It says exam 2 recordings. I put the new recording in and refresh it. I don't want to give you 7 announcements. Here's this announcement. Here's this review. Here's that review. I think that would confuse the heck out of me. So I will not do that to you. Any questions? All right, let's go ahead and let's start our PowerPoint. This week is hematology and immunology, and there's quite a bit on the exam regarding it. So let's try to figure this out. Well, when we talk about hematology, we're talking about that CBC, right? White cells, blood cell, red blood cells, and platelets. Those are the 3 bigs that we talk about. We know that we might do a CBC if we have a parent saying, oh, my kid is really tired, they don't do what they should do, or they look pale. We'll do a CBC and look. We do know that how we eat does give that iron to those blood cells, and that does give that energy to that child. So we got to worry about poor iron. One of the things that I think about with poor iron, think about a toddler. They hate to eat. They're finicky. So they're not going to many times eat those iron-rich products. And also, what are they drinking? It's no more iron fortified formula. It's now whole milk. Those are your at risk for your iron deficient anemias. And then we go into immunologic frequent infections, and then we're going to go into bleeding. So red blood cells, most common of all of those things that go on. We know it's not enough of the cells. Now, what does a red blood cell do? It carries oxygen and iron to the body. It's the food and the oxygen that helps it move and survive, right? So anemia, you're not getting food. You're not getting oxygen. So you're going to feel what? Blah, right? Fatigued. You're not going to have energy. That's usually why they come. The parents will bring their children in. They say in older children, not young infants, but older children, less than 10, is probably some sort of anemia. Now, what happens with anemia? You get a child in, you find out hemoglobin is 7 and 21. Listen to their heart. You're going to hear the swishing sound going on. When there's not enough cells, they bounce off of each other. There's lots of liquid, and there's like what we call hemodilution going on there, right? So what happens is you don't have oxygen, you don't have iron, and the heart says, let me beat quicker. Let me help the body, right? And you hear that murmur. And then after a while, if it's not replaced, the heart says, I give up. And it will go into failure, congestive heart failure. And it will go into there's no oxygen, so cyanosis, and then not feeding the cells, growth retardation. Now, there's many different types of anemias. B12 is that beef liver tongue that I would be looking at. And then you go into your cancers, the ALL or the aplastic anemia. And then there, of course, you lose blood, whether it's from nosebleeds is actually a big thing in children. Sometimes nosebleeds makes a diagnosis of other stuff. Usually it's ITP, which will go into that. And then we go into hereditary, like thalassemia. And then, of course, there's things like toxic ingestion, being next to a radiation plant, etc., or overwhelming sepsis. So, how do we, manage anemia? Well, we know that the diagnosis is because of what mom says, what they tell me about the child. That's the history. You pull the CBC and you see, well, something's going on here. Hemoglobin hematocrit are low or platelets are low because that's further on into bleeding. Now, we can replace the blood, give a blood transfusion. But why was that blood not where it should be? So don't just treat the symptom. What was the cause? And we're going to go into some of that as we go along. So we're going to give IV fluids, IV blood. We're going to give oxygen. And because they have no energy, we're going to put them on bed rest. So as we're assessing for anemia, how old's the child makes a difference. Where do they come from? Is it Mediterranean and thalassemia, African American, sickle cell? There's all different things that are little things. Also, a simple stool for occult blood. Anemia could be explained as a GI bleed. And we have to rule that out, don't we? We don't have to assume it's something else. Children don't like to be stuck. They hate venipunctures. So prepare the kid. Do as atraumatic as possible. If they're infants, make sure that we give them that pacifier, right? With the sucrose or breastfeed them during procedures. I've done those things. And those children don't even respond when I stick them. So iron deficiency anemia is because you're not eating enough iron. I think it's probably the most common of anemias that we do see. Why do we give irons, fortified cereals, and formulas to infants? Because what mom gives you goes away. So you have to replace it. But after 1 year old, we're going to go to whole milk, right? That's what it says. You don't have to breastfeed, you don't have to give formula. And then we know that they are like in this physiologic anorexia when they're toddlers, so they're not eating good. So these children are iron deficient anemia. We know adolescents are growing, that adolescent growth spurt, right? They're growing a lot. They're thinking they're too heavy, they're too fat. They grab a power bar, bottle of water, go for the day, save their money, don't spend it on lunch. They can do other things with it. And that's the reality of these adolescents. You know, Iron is things, the green leafy vegetables. Not all kids like them, and we need to try to figure out how can we incorporate it into their diet, things they like. And if not, we need to give them iron supplementation. We need to give them iron. Usually kids put it in the liquid. You give it, make sure it's in a straw if they can suck, because it will stay in their teeth. Also, remember iron orally, we give it with orange juice. Iron is broken down in the stomach by gastric acid, and orange juice just speeds up that, absorption of iron, okay? And we know diet will help. Now, sickle cell is one of those sort of thing that's an autosomal recessive disorder. We know if both parents have a trait, children have 25% of having the disease. Because you have the trait doesn't mean anything, but the disease is what we are going to be treating. Now, let me explain very simply what sickle cell is. Sickle cell is these little sickle shells, and these cells don't like to maneuver and go through bifurcations in the veins. And we know we go through big veins to smaller and capillary, the blood flows everywhere, right? So what happens is they obstruct, usually due to lack of, you know, dehydration, lack of fluids. So these children must be always drinking fluids, keeping their vessels as big as possible, getting those cells through. When it happens is these cells all of a sudden in a bifurcation will have the cell just be crooked and it blocks going down. So all the cells pile up here and below it swells, causing pain. And then down there is not getting oxygen and iron, right? And that cell death. So, what is our priority in sickle cell? Well, we know that many things can cause sickle cell anemia, right? And trauma, infection, fever, burning fluids, right? Physical, emotional distress, dehydration, all of that causes these things. You're going to see it in the hand, the elbow, the shoulder, the chest, the abdomen, you in the knee. It goes anywhere where there's blood vessels. Number one, you want to dilate those vessels, right? Because that's what the cause is. You can treat the symptom. The symptom is pain, they hurt. But why? These children have this very sickled shape because they can't get through the vessels because they're too small. So hydrate, hydrate, hydrate. IV, normal saline, open those vessels and get those cells to go through. It will decrease the pain eventually. Now, I'm not telling you to have that pain medicine in the other hand. I'm going to start that bolus of saline and give that morphine or hydromorphone or whatever is ordered because they hurt. I'm also going to give them those hot packs. What does heat do? Dilates vessels, right? Fluid dilates vessels. What causes sickle cell? Small vessels. Open them up, let them flow, and they'll feel better. Now, there is some thing with sickle cell. The cells don't last long at all. So I want to tell you, every time a kid comes into a sickle cell crisis that I've seen, I think the highest H&H I've seen is 7 and 21, usually 6 and even 5 and 15. So blood is always something, and this isn't an ER that we'll be starting because they need the oxygen. They need that iron in that blood. Also, it's usually due to a low-grade fever. So we'll be starting antibiotics. You know, any immunosuppressive child for any reason that has a fever over 100.5 needs to call their healthcare provider because you want to fight the infection before it starts something else going on. Now, children that are young, because of their immune system and what's going on, they're always placed on a prophylactic antibiotic. Could be one, and it's 10 VK was the one that was used where I used to work, up from 2 months up to 5 years old. Again, to try to prevent sickle cell crisis. We are going to monitor reticulocyte, making sure the blood is being formed in the body, and of course, blood transfusions as we need it. Now, there's no cure. These children are immunosuppressed. So we have to remember that. So, leading cause of death, bacterial infection. But treated well, these children can become adults and live a good life. So, what do we educate about? Early intervention. Have that fever of 100.5, call the doctor. Start that antibiotic. Or if they're getting that penicillin prophylactic, give it. One of the things about sickle cell, it can happen in the brain, it can happen in the chest. They look like stroke, right? And they look like a pulmonary embolus. So if a child comes in with sickle cell complaining of a headache, worry about that headache. It could be something like a sickle cell. These children are normal, great kids. Our goal is to prevent sickling. They're out and they're playing. Make sure they have plenty of fluids, but give them rest periods. They need to rest and they need to stop and to drink and hydrate. Now, thalassemia is from descendants of the Mediterranean Sea, that area. And I call it the rectangular shaped cells. And they burst. So what happens when it bursts? What's in a red blood cell? Oxygen and iron. These children, you're worried about iron going into the body, right? Now, there are many types of thalassemia, but for testing, they always do the worst, which is Cooley's anemia. These children are having so many cells bursting, their hemoglobins go so low that they're getting blood transfusions in order to survive. We don't see it at birth because you're born with mom, right? Usually about 6 weeks of age, their cells change, and then we see it. And what would we see? Well, we start with anemia. Body's not getting what it needs, so you're going to see height and weight where it shouldn't be, right? Growth failure. Absolutely, you're going to see it. These children do need blood transfusion. It's not like giving iron injections or oral iron has nothing to do with it. It's going to do nothing for this child. We need to give blood to this kid. The other thing is with all that iron in the cells being burst, we need to get rid of it. It's too much because these cells are a lot. So we either do Desferal, which is a medication, or an apheresis, which is a machine like kidney dialysis, and it pulls off the iron cells. So, care. These kids are always getting transfusions. They're always getting medications to get rid of the iron. These kids, they're sitting in sometimes weekly, bi-weekly, depending on the child and their condition. But it's a lot for a kid, and it's a lot for a child. And if you can imagine, they're getting these transfusions from beginning. These kids are going to have complications, antibodies, and all that stuff that's being formed. They can live in adulthood, but because they go from a normal hemoglobin after a transfusion and then it dies, then you don't. And then you give it and you have now a normal hemoglobin. What's the heart doing? It's beating fast, it slows up. It's beating fast, it slows up, causes heart failure. Also, where are cells formed? In the spleen. So we usually will take it out, but there is always complications of post-splenectomy sepsis and multi-organ, and that goes on. Maybe a bone marrow is a cure. We're not sure. Nothing sure about that yet. Now, aplastic anemia, what we usually call it is that profound depression of RBCs. We also call it lack of white blood cells or leukopenia, and then a lack of platelets, thrombocytopenia. So pancocytopenia is usually the description of aplastic anemia when you're having testing about it. What we do with this is very similar to leukemia. We're going to do an immunosuppressive therapy to try to regulate the body. We might give bone marrow. And it's a very similar to your leukemia. Now, hemostasis, problems with it. That means bleeding, whether it's platelets or clotting factors. Well, when you think of problems with bleeding, you always think of hemophilia, right? Hemophilia is an X-linked recessive. That means mommy is the one that transfers it over to the child. There's two types, and then one that's extremely similar, but we don't call it hemophilia. We call it von Willebrand. Hemophilia A is there are factors in the blood that stop you from clotting. There's 8, there's 9, and there's von Willebrand. Without that factor, they will bleed. So A is factor 8, B is factor 9, but von Willebrand is the factor von Willebrand and factor 8. That means if they're cut, they will bleed, 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 bleed. Now, how do we diagnose this hemophilia? Well, sometimes we know, and we go looking for it. But usually we're starting to see this overt prolonged bleeding, or we're going to see this bleeding into the joints and all these ecchymotic areas, right? Actually, epistaxis is a big thing with bleeding, and I'm going to go over that in a second. Now, hemophilia is a problem with factors. So low 8, factor 8, low 9, but a prolonged PTT. How do you know a PTT value? That's when you give heparin, right? It thins the blood. Well, so does hemophilias, all of them. Your parathyroid and your platelets, all that stuff that also sort of works a little bit with it, they're all normal. 8, 9, and PTT are not. So how do we take care of this? Well, if you're hemophiliac, you're going to be given home infusions, especially if you fall down, bump your knee, it's swelling up, it's bruising, you're going to be giving it. And I've seen parents do an amazing job with the child. I had a 9-year-old boy come in. It was a knee that was swollen, and they couldn't get a hold of their hematologist. And our ER physician said, yeah, go ahead and give it. Oh, you brought it with you? Go ahead. And I watched. I let the father do it. Probably better than I could have done almost. Well, almost. But the child and the father picked a vein, they did it, and they administered it. And that is going to help that joint from getting all the blood, and it can cause joint necrosis, right? So factor is those ones that are severe. That desmopressin is something that we also give for diabetes insipidus, which we'll go over next week. All right. And sometimes you can give this aminocoproic acid, but usually hemophilia I've seen, it's not ever mild. It's always that aggressive home therapy. So goal. Well, we've heard of RICE, right? Rest, ice, compress, and elevate. Well, what if you're 2 years old, 1 year old, and you find out you have hemophilia? Protect them. What if there's sharp areas on your coffee table or things that are sharp that are hanging out in the house? Make sure that we protect them from those stuff, pad those things, because bleeding can be dangerous. And our goal always with hemophilia, especially if they're in a joint, to stop it as soon as possible, because blood is caustic and will kill those joints. Yes, today we have hemophiliacs living a normal life, and we do better with those children becoming adults when we've really stopped the bleeding quick and their joints are okay, they're not in wheelchairs. There is a gene therapy going on, and we're working on it, still not there yet. Now, immune thrombocytopenia purpura, ITP. This is because of a low platelet count, because platelets work with bleeding too, right? Usually after an upper respiratory infection. And all of a sudden, a parent will come in. I've seen they have nosebleed, or they're there with bruising, or this little petechial purpura sort of little spotty little rash. And they say, my kid doesn't go outside, he doesn't play. What's going on? We do a CBC. Platelet count is less than 20,000. So what do we do? Well, it's IV immunoglobulins, anti-D. If you are in the hospital taking care of this child, remember, they're going to bleed. This is low platelets, so avoid venipunctures. Watch that kid, the gums, the urine, the stool. Make sure they're not bleeding. If they're having CBCs, make sure you're looking at platelet counts, what's going on. And then corticosteroids are used also in order to help control it. Usually, it will go away after 1 year of treatment. They call it chronic, not acute. But most of these kids are fine. Now, one of your NCLEX questions about epistaxis, you're going to see it when you do it. And it's a nosebleed, and it's like benign, right? What's a nosebleed? Usually they'll come in, nosebleed, it's one time, paint your nose with some Vaseline, keep it moist, upper respiratory. And then they keep blood nose, epistaxis, nosebleeds, nosebleeds. Then we do the CBC. Now, how can we teach parents to take care of this nosebleed? The thumb and the forefinger pinching the nose, leaning forward so they don't swallow the blood, okay? And hold it for 10 minutes. If it's still bleeding after 10 minutes, you need to get to emergency care. It might need cauterized, it might need these what we call nose tampons. All different things could be done, and we're going to find out, why are you bleeding like that? It shouldn't be that severe. Now, HIV/AIDS, we're going to the immune, right? Usually when we talk about it, it's either the adolescents with a risky behavior or it's mother to child. We know if it's mother to child, if the parents, the mother can get on therapy at 22 weeks, would be great. It's called a highly active antiretroviral therapy. That can help. But at birth, this is the most important. We need to give those antivirals at birth to improve their immune functions. Do you know, with children born of an HIV mother, I have a triplets that I can tell you about. One had AIDS, one had HIV, and one had nothing. So, what was the difference? It's the immune system and the way the body reacted to it. So, again, with HIV, it's all about education, especially for the adolescents. And with the infants, it's all about improving their immune system. Give me a second. All right, let's go back. All of a sudden, my computer. Give me 1 second to pull it back up for you. Apologize. The whole PowerPoint went down on me. So let me get back to where we were.
We're on slide 33.
You're the best. Thank you so much. Here we go. Thank you. So we know with the adolescents, it's all about education, right? We don't want those adolescents not, well, we'll just do it this way. Do you see what's happening to me?
Your PowerPoint keep going away?
Yes, it does. Hold on. My whole PowerPoint is frozen and I can't even get it back to Zoom. So give me a second.
Miss Bogart, I don't know if anyone else can hear you, but I can't hear you.
I can't hear you.
I can't hear.
So we were right here on this slide, correct? Can you hear me?
Yeah.
No, I appreciate you telling me. I don't know unless you tell me. Thank you.
Yes, sir.
No, with any problems with immunologic disorders, what's the treatment? Well, if you're lacking something, we're going to replace it. Packed cells, whole blood, RBCs, always remember transfusion reactions. And you're lucky today because we do have infusion pumps That apheresis is what I told you about, pulling off the iron. It's done by nurses today. And the other thing about bone marrow aspirations, kids do get them. Have you ever seen a bone marrow aspiration? You're going to hear a crunch, crunch. And even if you're standing next, and it's like, you're going into sternums and to hip bones, and you can hear it. And that's scary for a child. Yes, we do sedate them. Yes, we give them stuff for pain, but let them know you may get some pain. I'm going to do everything possible to make it as little as possible. That's all a kid wants, and they want the honesty. So if both parents have sickle cell trait, what's the chance of each child having sickle cell? It's 1 in 4. It's 25.
25. Oh,
Yes, 25. All right, let's talk about some cancers. We have leukemias and we have lymphomas. Leukemia, we have ALL, lymphocytic or myelolytic leukemia, AML. ALL is the better one to have than the AML, okay? It is this, the cells are being produced, but they're immature. So the white cells are there, but they don't work, like I said before. So your white blood cell count may be 0.1 or 0.01. What does the white cells do? It helps with infection, right? It protects you. So without it, can you imagine these children? So what do you see? These kids will come in with bruising. They'll come in with a fever. They'll come in with pain somewhere. And they'll look pale. They just don't look good. We'll do a CBC. And we're going to see a very low white count and immature leukocytes when we do a smear. We're going to do a lumbar puncture, right? That left lateral decubitus position, put it into their back and get that fluid. And we're going to do a bone marrow biopsy. And always remember, be honest with those children. Now, in leukemia, once we decide that's it, they always put in some sort of port where the kid isn't always going to be stuck with a needle. There's 4 stages of it. The first is the most important. It's called induction therapy. It's the first 4 to 6 weeks. And actually, the goal is achieving remission. Now, we know some of those cells are going to hide, right? So we're going to do 3 other things. We're going to do central nervous, the intrathecal. We're going to be doing some more, and we're going to do a maintenance just to be sure all the cancer is gone. So induction could be 2 or 3 different chemotherapies, goal of remission. Now, sometimes chemotherapy doesn't work, and we need to do what we call a stem cell transplantation. This is that transplant that infection is the highest for failure, okay? Now, you don't have to have the same blood type, okay? It's not like that. Now, the donor is better yourself, right? And that's your umbilical cord that was saved. That umbilical cord blood could be this being done. Yes, we do like siblings, but it is, and you could have somebody else. You don't really need it. Now, the thing with leukemia, and they're going to be getting this port put in. They're going to have all these procedures put in. They hurt. There's always an area that hurts. They have no immune system. Their white cell is nothing. So infection, hemorrhage, anemia are all the things. Does any of you ever want to work in the oncology area of pediatrics? Do you realize today I see these postings for wanted an oncology pediatric nurse, $25,000 sign-on bonuses. Yes, ma'am. And you need to go work with it for a year, get certified in chemo, and they will pay you to do these things. It's a highly sought after field. Yes, it is hard. Many of your kids die. But again, I've seen many kids die in my cardiac world. The thing is not that they died, it's what did you do for that child and family when they were alive? Do you know how many children who have died who still talk to me, who still send me messages because of how I treated them so well? So it does make a difference. Nurses do make a difference. So, what is a prognosis for leukemia? Well, in leukemia, what is your white count? Was it 0.1? Was it 0.1? How old were you? Was it the ALL or the AML? Were you male or female? And remember, they're going to be going through a lot of transfusions because chemo kills good blood cells and it will require transfusions. So, are you A positive or are you a very rare blood type? Makes a difference. Well, in cancer, depending on what's going on, we might do radiation chemo to shrink it and do surgery. And that's part of what this is telling you. Again, cancer, what are the signs and symptoms? Well, I had a neighbor who ended up with ALL. She went into the ER complaining of knee pain. She had some bruising, she had a fever, and she didn't feel good. And they diagnosed her with ALL. When they went and looked at her more, of course, the lymph nodes were there. Not necessarily all of them have vision changes, but it could, depending on where they are. Now, as we're giving all of this good chemotherapy, what happens is it does kill a lot of the cells. And it does decrease neutrophil counts. Neutrophils are that cell that helps with infection, right? So, one of the things that is said, if you have a patient, whether they're ALL or another child overwhelming sepsis, a low neutrophil count is very dangerous. They don't have anything to fight infection. So if we see a child with a fever, low neutrophil count, we're going to treat them like they have an acute infection. Collect all of those cultures and blood stuff. We're going to be starting them on antibiotic therapy. And because of that, we're going to prevent infection. Because infection in a child who has leukemia is dangerous. It could kill them. They have no immune system. Hemorrhage is a big deal, again, because of all of those blood transfusions that were given, because of all that chemo that's killing all these cells. So these kids need to be protected. They need the bubble, as we say it as parents. No outside, don't get them on their bike, no skateboards, and all that good stuff. We know anemia is common. That's why we give a lot of those transfusions. Nausea and vomiting. You think of chemo, you think of vomiting, right? So make sure that they're medicated. And because they get a lot of swelling in their mouths and they don't want to eat, make sure that they take enough in and their nutritional statuses keep up. This is that time, high protein, high calorie, high fat. This is when you eat whatever you want, and the more calories, the more fat, the better. As I said, the mucosa gets irritated. If we're eating that good stuff, make sure it's nothing that's going to bother their mouths. Now, sometimes with all those low blood counts, you worry about constipation. They have pain, right? Constipation is part of it. Then they're pushing down and they could cause strokes. You got to be careful. Keep them on stool softeners. And again, keeping them up with pain. They can have blood in their urine. And of course, we know chemo causes loss of hair. What I used to do is give these kids ribbons in their hair. I had all colored ribbons. And then I would give them ribbons. We'd make them ourselves. And I'd put in one in my hair too. So it became not a bad thing not to have hair or losing hair. Have you ever thought about the steroids that we give? Sometimes we give a lot, right? We got to be careful. These kids get puffed up. Older kids are going to be conscious of it. So make sure that we're aware of that, not putting them in tight clothing that make them feel self-conscious, being careful of salt. We don't want them to feel, less than. Again, for procedures, make sure that they're sedated. Explanations always on developmental levels, and using topical and local anesthetics. And we now are using deeper infiltration for bone marrow. As I said, it goes in and it's crunch, crunch. So we really need to be prepared for that and medicate for that for no pain or minimal. As in pain, just like any other child in pain, make sure that you give it, that you don't withhold it, that you call in the pain doctor, making sure that you're doing all the stuff. And always, always titrate those doses, increasing them as we need it, because these kids hurt, and I don't want them to remembering pain. I don't think you do either. So health promotion is always important. When we look at kids with cancer, they still need all this care. I think, excuse me, one of the things that we think about is immunizations, right? Live attenuated viruses, they can't have. Inactivated vaccines can be used, and you've got to be careful even what the family receives. Varicella vaccine is the varicella, the disease is extremely dangerous to this child. So they need that vaccine. So being aware of these things. Now, lymphomas, this is your lymph nodes. You've got Hodgkin's and non-Hodgkin's. Hodgkin's is usually from the neck up. And what you'll see is like these pictures, big, thick, protruding type of nodules. Hodgkin's, it's like a lodge. It's like that neck up, all right? So in this area, they are painless. They're firm, and sometimes because of the pressure against the airway, you might see a cough or whatever. They do a biopsy, they'll find the Sternberg read cells, and then they'll take out and remove it. They'll do radiation. Remember, never ever wash off those purple, usually purple marks, leave them there. And usually these kids do really well. Again, with any Hodgkin's, you always worry about infertility because of radiation or chemo. Now, non-Hodgkin's is not a lodge. It's not a house. It's not just in a place. It is all over. It is diffuse. Okay? This one takes more to be able to take care of. We'll do the biopsy. We'll find it. We'll give them aggressive radiation and chemo. And again, this is almost like your leukemia, induction, consolidation, maintenance, chemo. It is big because it's diffuse. The Hodgkin's, we can take it out, but non-Hodgkin's is all over, diffuse. There's not one lodge of Hodgkin's, there's multiple. Now, brain tumors in children is the most common solid. And what do you see with brain tumors? Usually you'll see headaches and vomiting. Headaches wake them up at night, when they're sleeping. Vomiting, not related to what they're eating. And then all of these other things, swelling in the brain, if it's occluding where the cerebral spinal fluid is moving. It could affect the eyes because it's pushing against the eyes. It could be something to do with the way that they walk, depending, again, where is the tumor related? And then diabetes insipidus by the pituitary gland, right? And growth failure. How do we diagnose this? Well, first, you're going to see headaches, wake them up at night, vomiting, maybe that they're falling over, things that aren't normal. We do the MRI, and we don't do LPs on brain tumor. We don't want to move it. It will displace it. So unless we see those increased intracranial pressures are causing the headaches, we don't touch that. So we do radiotherapy, we shrink that tumor, we give chemo, and we do surgery. Post-operatively, it's all about whatever the doctor orders. Where are we going to keep the level of the head, the positioning? And the big thing with brain tumors is not to overload these children with fluid. You don't want to put extra fluid in their brain. They're already overwhelmed in the brain. And our goal is get them back to where they're going to be. Now, neuroblastoma is very, very uncommon. I'll just say that it's an abdominal tumor that goes to the brain, and it's usually we can't do much with it because it starts with the abdomen, it's already metastasized. Again, it's chemo and radiation therapy and whatnot, but I'm telling you, it's not great outcomes. Bone cancers. Bone cancers, we usually find where they're limping. A kid starts limping and they're fine and they're hurting and you're wondering why. So our diagnosis is important, and then finding out where is it at. Bone cancers, many of them, we call them osteosarcomas, right? Osteo being bone and sarcoma meaning cancer, and it could be anywhere. With any cancer, you'll see that weight loss or infections, etc. Most common that we see in these bone cancers is osteosarcoma. Commonly, it's in the femur bone. That femur bone, you can't just remove the tumor. You got to remove the whole bone. And removing that whole bone, where are you going to put the knee, right? Where are you going to put a prosthesis? How are they going to walk? Well, they take the knee and put it back into the hip. And this is called salvaging the limb. That is our goal here. Wilms tumor. It's nephroblastoma. It's a renal tumor. It's a tumor that is in the abdomen, and usually they don't see it. I've seen one case in my life. It was a little 3-year-old boy who came up after the Haitian earthquakes that we found as healthcare professionals in Haiti, and they were sent to me. A religious group brought him into the ER, had no clue what was going on. So here I am. Well, where do I place this kid in the ER? Is he high priority, low priority? So I did an assessment, right? I went and, okay, and he spoke French. So here I am with a 3-year-old boy in a new place, nobody he knows speaking French, and I had to do an assessment. Well, we got the vital signs done. I listened to his lungs. I felt his abdomen. That right lower quadrant had a softball-sized tumor. And I don't know why, I knew it was a Wilms tumor. And I knew that we shouldn't touch it and manipulate it. You'd be really amazed how many stuff that you've learned when you see it all of a sudden pops in your head and you know what to do. So we do sometimes radiation, sometimes surgery, but we go in and we remove it. Now, when we remove it, where are the kidneys? They're in the back of the peritoneal cavity, right? So our really big thing is now monitoring bowels because they've been manipulated. Also monitoring the kidneys because it's a nephroblastoma. Rhabdomyosarcoma, soft tissue. It comes out of eyes or ears. And again, this is under 9 years old and something that needs to be removed. Retinoblastoma. This is like going outside at night with a light on and you see your dog or cat with these shiny eyes. That's what it looks like, just like this picture. It's this whitish glow. It's called cat's eye too. And we do radiation chemo and we take and we remove the whole eye. We need to find out. I've seen one. That's all I've seen actually in the emergency room. And the child was 8 or 9 months old, never had any problems. So I said, have you had anything, any problems, signs and symptoms? No, not at all. And they were there for something else. And we found this retinoblastoma. Germ cell tumors. When we talk germ cell tumors, this is a lot about ovarian tumors. It's also about testicular tumors. You know, every month we should do breast exams as adults, right? Adolescents up. Well, men should do testicular exams. Well, this one 18-year-old boy came in complaining of testicular pain. When we went and we looked at his testicles, they were huge. So we knew the outcome wasn't good. They did an ultrasound of his testicle and then they did a chest and abdominal x-ray. He had metastasized everywhere already. He waited too long to come in. You know, we've heard about, who is that writer who, bike rider who all over Europe. Anyway, he also had testicular cancer and he beat it. It's because if you catch it quick, we can get it out and it will be okay. The liver has such a great autonomy to grow back. Go back, take it out, and they actually do well. Now, cancer survival rate used to not to be as good as it should. In fact, probably the survival rate is more than 80% right now. We know that cancer and the changes and the medications and the way that we treat it really, really works today. So how many of you have seen on the Facebook these little pictures, kids cancer free? You know, when I see them, it makes me happy. What about you? Anybody want to do a cahoots? Okay, John, we'll do it for you. I think there's like 50 questions, so we'll be out a little bit early. Remember, as we're going along, you don't understand something, stop me. I really appreciate it when you do. Let me know what's going on. All right, let's go ahead and get started. I think we have everybody who wants to do it. Pediatric hematology and cancer. Which statement best describes a neuroblastoma? Remember, it said tumor that starts in the abdomen and goes to the brain, right? I just briefly went over it because we know it's not common. You might or might not see it. And usually diagnosis is after it's already to the brain, and it's usually not a good outcome then. What is priority treatment for a newborn of HIV positive mother? I've seen HIV positive infants by 1 years old turn negative, and I think that's great. And it's the reason because we have all of these drugs today. And it's because we want to improve the infant's immune system. We give them the antivirals, right? And that helps them fight it and it gets rid of it. And I've seen them positive go negative. So it's not always that death sentence of HIV. What symptoms are sickle cell anemia? Do you have a cell that occludes a vessel? It doesn't go down and it swells. What do you see? So it's some sort of swelling. And pain. Pain is the big, big, big thing. You might have vision problems if it's the brain. And then if it sits there for a while, the lower extremity, the lower arm, wherever it's at, it's not getting oxygen, not getting, what it needs. So delayed growth. Sickle cell anemia affects which cells? And it's red blood cells. Sickle cell anemia is the oxygen and iron um, cells that carry those things. So red blood cells. No oxygen, no iron, the body's not happy. What kind of hematocrit would someone with sickle cell have and why? Remember, I always told you when these kids come in, because these cells are such a short life, I'm always giving blood transfusions. Always. So it is lower always. If I have a 7 and 21, I'm actually happy. I've seen as low as 4 and 12. These kids were really, really sick. They waited way too long to come in because these cells, they die. They're not normal, they die. What is the treatment for sickle cell anemia? What's the first thing you should do? Priority care. What's the big deal with sickle cell anemia? The vessels get smaller. Blood can't get through. IV fluids, number one. Pain medications, of course, on the other hand. Blood transfusions for those low blood counts that you're going to see. And then in the end, bone marrow, if we need to. What is the reason children with iron deficient anemia are easily tired? What is iron deficiency anemia? And why are they tired? When your body doesn't have oxygen and iron, it doesn't have what it needs and it becomes tired. Yes, very good. Decreased. Aplastic anemia includes a depression of which blood cells? And remember, aplastic anemia, the treatment is very similar to leukemia. Body's just not doing what it's supposed to do. So you're going to have problems with bleeding, you're going to have problems with infection, red blood cells, white blood cells, and platelets. Most common type of anemia is Iron deficient anemia. Good. Yes. What causes pernicious anemia? Remember, it's that big, beefy tongue. It looks like raw steak. That's your B12 deficiency. Very good. Which symptom is the single most common symptom of anemia? You don't have red blood cells. You don't have oxygen. You don't have iron. How would you feel? Yes, fatigue. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, these are those rectangular shaped cells, Mediterranean, that burst. What's inside the cell? And what would they be at risk for? Well, they're losing oxygen and they're losing iron. In fact, this is the diagnosis where they're going to be getting some sort of chelation therapy, whether through medication or through apheresis. It really is a problem because they're bursting that much. This child will have blood transfusions. What lab values would you see with a hemophilia? We know that the factors will be low, but initially, like in ER or urgent care settings, a CBC doesn't show us that. So what would we see? PTT's prolonged, but all the other stuff is fine. It's the PTT that will give us the hint. And then when a week later, the factors labs come in, we'll know which factor. Priority treatment for a child with sickle cell crisis is IV fluids. What is sickle cell? Small vessels the cells can't get through. You can treat the pain, which is a symptom, or you can treat the cause, small cells. Open them up with fluids, right? Get those cells through. Very good. What is immune thrombocytopenia purpura? ITP. Say that 3 times fast. I say ITPP platelets. That's how I remember that. This is after an upper respiratory. Platelet counts are 20,000. I remember it. ITP. P is platelets. And that's the other part of the bleeding coagulopathy sequence, right? You need them. Thrombocytopenia can cause the following symptoms. What is thrombocytopenia? I'll ask you that. And thrombocytopenia means your platelet count is low. And of course, it's hemorrhage, bleeding, whatever, and epistaxis. That is thrombocytopenia. Very good. A multi. A child with hemophilia has fallen and the knee is swollen and painful. Treatment would include what? I mean, yes, they're going to give home therapy, most likely, right? They'll give the factor at home if they know what it is. But it's what we call rice, which is rest, ice, never, never heat. It's contain, ace bandage, and then elevate. We're not going to exercise. We're going to put cold packs on them and elevate it. Very good. What is a priority nursing action for a suspected blood transfusion reaction? Walk in and this kid is rash everywhere. Went from a normal fever, it's 102. What are you going to do? I've seen it both ways. Rash and fever. Stop it. Stop it. Don't even flush it through. Take it off and get rid of it. And of course, call the doctor. Let him know. A child is admitted with neutropenia. Which nursing action takes priority? What is neutropenia? What does that mean? Well, that's the neutrophils, right? That means low, which is what? A white blood cell. So what nursing action is priority with low blood, white blood cells? It's hand washing. That's always number one with neutropenia. You're not going to put them on any isolation. It's always hand washing. That's always it. Which symptom would a healthcare professional expect to see in a child with leukemia? Just like my neighbor. Their CBC values are all over the place, so they're going to be bruising, they're going to be tired, and it's usually that bone pain. Very good. Your child has ALL, the recent lab values with a platelet of 10,000. Your nursing action, what do you need to know how to treat that patient? Platelets of 10,000, does that mean anything? What could happen with a platelet count of 10,000? Very similar to ITP, right? Bleeding precautions. Remember, low platelets, no matter if it's ITP or overwhelming sepsis or ever it's caused from, always platelet counts low, it's bleeding precautions. A multi. Child's placed on bleeding precautions for ITP. What interventions would the nurse do? So the kid is bleeding, ITP, lack of platelets. What are you going to do? All the above. Never put an injection in. If they're in the hospital, monitor their daily CBCs. Always look for bleeding, and then corticosteroids are used quite a bit with it. So if symptomatic, sometimes they're used, etc. Child with a Wilms tumor. What action by a nursing student causes the faculty member to intervene? What's a Wilms tumor? What could a nursing student do? And she's going to be touching that belly all over the place. Remember, it's very fragile, and little pieces break off and metastasis will go around. This is why we don't even do a biopsy on this. This is something that we protect the abdomen. Cancer of the body's blood-forming tissues, including the marrow, is called what? That is leukemia. A child with ALL has a fever of 100.5. They're at home. So what should they do? Remember I said any kid who's immunosuppressed for whatever reason, if they have a fever, it's dangerous. They don't have this protective immune system. They need to call the doctor, whether it's sickle cell, cystic fibrosis, whether it's ALL, There's no immune system. Call the doctor. Most likely they'll tell you to go to the nearest ER and we'll start treatment, draw bloods, and give IV antibiotics. A child's having a bone marrow aspiration. Why should you tell that child? You know, the one thing with children, always be honest. Let them know it's going to hurt and tell them you'll hold their hand, whatever they want you to do, okay? It's not fun. Most common clinical manifestation of a retinoblastoma. Where's the retina? And that's that cat's eye reflex. I've seen one, and it reminds me of going outside and seeing an animal in the distance. There's a light shining, and you see these white, shiny eyes. That is exactly the same thing that you see with these children. Your child's been diagnosed with a retinoblastoma. What information is important? So you've got this tumor of the retina. What should you know? Part of the history, right? And it's all about getting history, any signs, any symptoms, whether they're infections or tearings or blinks or whatever. It's what have you seen, guys? A goal of surgery for a child with an osteosarcoma is what? You know, and that's a great picture of an osteosarcoma of a femur. The one on the left, you can see it. What is our goal? We want to salvage the lower part of that leg and take it from the knee up, put it into that hip joint so there's a place to put a prosthesis. It just works better than taking the femur and the whole leg out. True or false? Immunizations causes autism. Absolutely not. You know, there was this fake false study that came out. The physician was proven wrong and his license was taken away, but it created a lot of havoc in the world of autism. It was the fault of the chicken pox, the varicella vaccine, and it is not. A child's complaining about those skin markings for that radiation therapy. They should be told what? Those purple markings. So radiation directs the radiation to one certain little place. Leave them there. I used to have one of these things I called washing off the marking sort of parties, you know, and it made it a big event when we could take it off. Leave them there. We need them. A multi. Nursing care of a patient with immune thrombocytopenia purpura, ITP, remember P platelets. What does that mean? Just like the other question, we want to give no IM injections. We're going to look at the CBC and corticosteroids PRN. Now, why not IV fluids? What does platelets and bleeding have to do with fluids? IV fluids is only for sickle cell because it's not in the vessels. It's only just a lack of platelets. IV fluids is not going to do anything for this child. This is a very common mistake that students make. So remember, ITP does not need fluids. It just needs you to monitor it. No IM injections, monitor blood counts, corticosteroids, PRN. When distraction is used, it helps what? I used to do the 3 p.m. YMCA dance in the middle of the cardiac intensive care unit to make these kids forget about them hurting. And they'd be in their rooms doing YMCA with me. And again, distraction made them feel normal, made them feel silly. So it shifts that attention away from why they hurt, what's going on, and it really does help. Kids are great and resilient with distraction. What assessment question needs to be asked to a child with possible rheumatic fever? What do you need to know? Any sore throat. Remember rheumatic fever, and if we go on to week 8, it's going to be acute glomerulonephritis. Rheumatic fever is caused by a strep throat that was not treated completely or at all, okay? Strep is a big problem when not treated. One of two conditions. Signs and symptoms of asthma. Last week, what do you see? You know, I'll always test you about last week. Coughing, shortness of breath, and remember, it's expiratory. Croup and epiglottitis is inspiratory because it's only up here. Asthma is down there, it gets trapped. So it's expiratory, prolonged. A multi. What symptoms should be reported to a healthcare provider with a child with sickle cell disease? Well, chest pain could be just, the chest and vessels, or headache could be stroke. Chest pain could be a heart attack, right? And with sickle cell, all of the things are possible. So chest pain and headache. Headache could be an occlusion in the head. An absolute contraindication for nasotracheal suction include which of the following? Again, another repeat question, testing your knowledge. It's all of them. You don't want anything in the upper airway that's a problem. Epiglottitis, croup, or tonsils, you don't want to go in there and put a tongue depressor or suction in there because it's going to create more swelling, and then it will create your airway to be gone. Iron dextran is given which route? We give it for iron deficient anemia, right? Of course, we'll try diet first, oral stuff, with orange juice through a straw. Iron dextran is the last possibility because, kids don't like injections. But iron is caustic and it burns. So it is the Z-track because we push out the skin, push it in, and then we lock and load, as I call it. And actually, that was the first injection I ever gave was iron dextran. It was a 40-year-old woman. So can you imagine your first IM injection with Z-track? That's what I did many years ago. A child was to receive their own bone marrow. This is called a what transfusion? So they had some of their cord blood stored, right? What is it? Automatically mine is the best, right? And all the others is everybody else. Good job. What cancer may present with painless, firm, and enlarged cervical nodes? This is all upper. And that's all of my lodge is up here, okay? Big and thick, and they can remove it, radiation, and remove it surgically. Hodgkin's lymphoma. A multi. When teaching about sickle cell disease, what would you include? You're going to give a lot of fluids, right? Give the pain medicine quick. If it's warm outside, that's great. If it's cold, the vessels will restrict, so dress warmly. And any temperature, you need to get to that doctor. If you're going up in an airplane, also drink lots of fluids. Anything to keep those vessels open. Thalassemia major is treated primarily with what? Remember, it's that rectangular shaped cells and they explode, and the body doesn't produce proper cells, so blood transfusions is how they live. A multi. What are opportunistic infections of HIV? I remember back in the 1980s, I went to work at a big county hospital, and we had a patient with HIV, and they went into respiratory arrest. And they told me it was PCP pneumonia. I had no clue what that meant. I had to go home and look it up. It is PCP pneumonia, and it is Candida yeast. So these are things that we will be checking. A multi. Treatment of osteosarcoma includes bone cancer. So we can either transplant, we can either do an amputation or salvage the limb. Our priority is to salvage the limb, but we do chemo to make sure that cancer isn't anywhere else. Stem cell transplant has nothing to do with osteosarcoma. It's salvaging the limb so there's somewhere to put that prosthesis. A multi. Who are the best donors for a bone marrow transplant? So if it's not me, who else? So if me, yes, but your siblings, your brothers and sisters, you're made from the same two people. That's actually the second best that we could use. What is the most common opportunistic infection for children with HIV? And it's actually PCP pneumonia. That is the most common. Yeah, you might have that candida, that, fungus in the mouth thing, but most of the time it's the lungs that we worry about. What would you consider to be neutropenia or a low neutrophil count in children? Remember I said neutropenia, there's nothing to fight infection, and especially if they have a fever. This is a child, if you're given a group of children, I would see first. This kid is going to crash and burn unless we intervene immediately. It's usually less than 500. The other ones, 750 to 1,000, borderline. It's usually like the green one, 1,200 to 2,400. But that low one, you have no immune system. That kid is going to go into septic shock very quick. Unless you treat it, give antibiotics. A primary characteristic of a brain tumor is so what happens is that brain tumor grows and you're going to see vomiting, not related to eating, and you're going to see headaches that will wake them up at night. It's not just occasional. And of course, your balance is going to be off because it's wherever it is in the brain, it could cause you to have no balance. The optimum treatment for osteosarcoma is, what do we really want to do? What's the best outcome? It is salvaging the limb. You cannot just take a piece of a femur bone out. The whole bone has cancer in it. The whole upper leg has to be gone. Okay? Which means you only have the bottom part from the kneecap down, which has to be reattached into where the hip bone is. And they're doing it quite successfully now. It's called salvaging the limb. And there's a place now for prosthesis. And last question. A child is receiving the induction of chemotherapy. What does that mean? So it's the initial first stage of that chemo, and the goal is remission. Remember, the other 3 stages are to make sure there's no little hiter, little cells anywhere, so it won't reoccur. So let's see how we did today. Number 3, it's a K. Congratulations, Kay. Corey, good job, Corey. Number 1, Jen. Good job, Jen. Whoop, whoop. Sarah and John. You know, this was a really good cahoots. It gives you a lot of those concepts that you need to know. Remember, there's a lot of your exam reviews this week. Remember, next week is you have your exam. Come a little bit early to try to set you up so that we can get you out on time and then give you enough information for that week 7. We're either going to do a cahoots or we're going to do a PowerPoint, and that will be your decision when we get there. Any questions? Good night, guys.